I'm What is up, Z-Pack? It's your boy Z-Dog MD. It is Thursday in some month, in some year. I don't even care, because today we're getting real. This is Incident Report. We are going to talk about pharmacy benefit managers as soon as Logan fixes whatever he just broke.
Did I fix it?
Did you fix it?
Wait for it, Tom.
It's
on a delay.
There we go. We're talking about pharmacy benefit managers, or PBMs, peanut butter and money. You wonder. I will tell you, they are the least understood entity in the pantheon of terrible entities that work in the American healthcare system. Everybody from health insurers to big pharma to big medicine to big whatever, big hospital. There are many big players. There's a lot of money in a $3.2 trillion economy. But the pharmacy benefit managers are one of the groups that is least transparent. And there was an article that we shared in the title for this, and we're going to go through this right now. It is this: how price-cutting middlemen are making crucial drugs vastly more expensive. An LA Times article. And then we're also going to talk about a Bloomberg Businessweek article. Drug costs too high? Fire the middleman. Both of these have promising titles, but let's dig into it a little bit. Now, in the first one, you see a picture of Heather Bresch, the CEO of Mylan, who became notorious for jacking up the price of EpiPen, which saves little children from all kinds of death. $600 an EpiPen or something like that. Now, Heather, in her testimony, said that $300 and some of that goes to middlemen. Now, who are these middlemen? How does this all work? Let's go back and describe what a pharmacy benefit manager is. And there are three big ones that account for 70% of all the drug-related transactions in the US. Express Scripts, Optum Rx, which is owned by, wait for it, United Health, my favorite company, and Caremark, owned by CVS. So these are the three big ones, and there are smaller companies as well. This is what they do. They kind of sprang up in the 60s, I believe, if I'm reading the article correctly. And the idea was they are the sort of administrators who help health plans, i.e. insurance, and businesses, many of whom are kind of de facto health plans in themselves because they self-insure. In other words, they're paying directly for their employees' healthcare costs, like a Home Depot or someone like that. These pharmacy benefit managers exist to, first of all, develop formularies of covered drugs so that not everything is covered, because otherwise they would go broke, right? So they choose which drugs are covered. The next thing they do is they negotiate with the pharmaceutical companies, purportedly on behalf of health insurers and us, patients, because we're ultimately who the health insurers ought to be serving, to negotiate drug prices that are more affordable. And they can do that because they have the leverage of size and all of that. So the idea is that they are there to save drug cost money and to administer drug benefits rationally, efficiently, with a greater degree of cost savings to the ultimate customer, which is us, the patient.
That sounds like a great idea, Z. It's probably working out grand.
Like everything in healthcare, of course, it works exactly as intended. When it started, this seemed to make a lot of sense because people were like, cool, someone needs to push back against the drug companies, negotiate with them. And what they ended up doing is that the pharmacy benefit managers would tell the drug companies, okay, if you want us to put your drug on a formulary and offer it to this particular health plan, you're going to have to give a rebate on the cost. So you can charge X, for whatever reason, but you have to pay back Y. And we will pass on that savings to the health plan, therefore really accomplishing our responsibility, which is to lower prices, make it more efficient, et cetera. Now, how do you think that's going to work out over time in a $3.2 trillion economy? I'll give you a hint. The PBM business is now worth around $200 to $300 billion a year. Billion with a B.
Which equates to 10% of total healthcare spending in the US.
Yeah. So if you think this isn't a potential minefield of conflicts of interest, of price gouging, of kickbacks, of bribery, and of general opacity, meaning people don't actually know what's going on, that's exactly what's happening. So the article goes like this. It starts talking about diabetes drugs, insulin. And this has been something that's been on our show a few times now. Insulin has soared in price to around $300 a vial. And when we did our show on insulin prices, we didn't mention directly pharmacy benefit managers, because I'm also still becoming educated on the complexities of this. So looking at this, $300 a vial, and they interview a doctor here, Dr. Hirsch, who's an endocrinologist, professor of medicine at University of Washington, and he says it's becoming common to see patients intentionally withholding their insulin because their copays and their part of what they have to pay, especially if they're uninsured, is so high that they're cutting back on insulin, which, as we know, you really can't cut back on without losing limbs, without causing complications, without ending up in the emergency department with ketoacidosis if you're a type 1, or ending up with long-term complications and potentially hyperosmotic, non-ketotic ketotic acidosis if you're a type 2, all kinds of complications out of the scope of this talk. This is a huge problem, right? So these drug costs matter. Now, is it purely a pharma thing? Is it the pharmaceutical industry that's effing us? Answer is maybe not. Maybe it's multifactorial. They are a huge problem, but let's read on. So he says a good share of the blame lies on pharmacy benefit management firms, these big three in particular. They're middlemen. We thought originally they would make the distribution of medications easier, more efficient, and cheaper, but now they want a cut of the money, and over the decades, they've wanted more. Now, of course, when there's $3.2 trillion and $300 billion specifically in this particular space, of course it's going to create these for-profit grabs. Now, what was interesting is in the 90s, I think it was, the article states that the drug companies actually started buying up the PBMs because it made sense. They would just merge and then they would control all aspects of it. And of course, the federal government was like, no, you can't do that anymore. So instead, insurers started buying them and CVS started buying them. So the three PBMs that dominate the field collect more than $200 billion a year to manage prescription services for insurance carriers, covering 180 million Americans. That's half of everybody in the US, right? More than half. So we've got Express Scripts, Optum, and Caremark, and then the expansion of PBMs, the pharmacy benefit manager's role, illustrates the opportunities for profiteering in America's fragmented healthcare system. So they originated as these intermediaries to help health plans process claims, steer doctors and hospitals to cheaper drug alternatives, and allow insurers to combine their customer bases so they can get greater leverage when they're negotiating with pharma. Sounds great, right? Well, here's a twist. In the US, it's like 8% or $8 of every $100 goes to the PBMs. In the rest of the world, the middlemen get like $4 or less. So something we're doing in the US percentage-wise doesn't make sense, and you can bet where that goes, into profits. So over time, they became just another special interest. And this is the LA Times article, which is traditionally biased against corporations, just so you know where the bias in the article is, right, Tom? I mean, they're going to kind of go after the big companies in general. So just understand where the bias is. So the next phase was a wave of mergers and acquisitions, and that's when they were bought up by CVS and all those other things. Now, the position of the three major PBMs at the center of the drug distribution system appears to be unassailable for now. And the reason they say that is CalPERS, which is California's public retirement program. It's huge. It's like a country in itself, right? It could be a national government in many countries. It's that big. They just awarded Optum Rx, which is, again, United's owned PBM, a 5-year, $4.9 billion contract to manage prescriptions for 500,000 members and their families enrolled in their non-HMO plans. So the only other finalists in the bidding were, wait for it, CVS Caremark and Express Scripts, the other two big PBMs. So already we have a pseudo-monopoly, and we have practices which, as you'll see, are not entirely transparent. So what are we going to end up with? A $600 EpiPen and a $300 vial of insulin. Let's keep reading. Today, the firms extract billions in price concessions from drug companies, that sounds good, who are eager to remain in their good graces. So the drug companies are kissing their asses because if the big PBM that serves, Anthem doesn't list, Lipitor on their formulary, that company is screwed, right? So these are huge, there's so much money at stake. So the drug maker's goal is to secure spots on the PBM's formularies, the rosters of approved drugs, for their health plan clients. Now, to do so, drug makers offer these rebates to the PBMs for each prescription filled, and they agree to a dizzying list of other fees. So in order to kiss the PBM's butts, they got to give rebates and these other fees. The PBMs say that since most of those rebates and fees are passed on to the plans, the health plans, the insurers, and subsequently to patients, good luck with that, they fulfill their promise to reduce drug costs all along the line. Okay, how do you think this is going to work out, Tom?
It probably is working flawlessly, see?
Totally flawlessly. So The PBMs are sitting at the center of a big black box, says Linda Kahn, a drug pricing consultant to the health insurers, which, by the way, if your job title is drug pricing consultant to health insurers, you need a new title because that sounds icky as F. We don't curse on this show. We curse on the next show. So
How much should this drug cost? Probably $1 million. I mean, why not?
Why not? I just consulted. Get paid, Linda Kahn. So they're the only ones who have knowledge of all the moving pieces, the PBMs. Among the murky areas are how much in rebates and other fees PBMs collect from drug companies and what share gets passed on to health plans. We're going to talk about this in the Tribe Talk after this. I have sat in on these conversations with big PBMs, and I will tell you it is dirty AF. Whatever the pass-through critics say, it's forcing prices up because if there's a big rebate, then what does pharma do? They just raise the price of the drug. So it's just like the rack rate at hospitals. Hospitals know that insurance is only going to pay X, so they charge X in order to get the percentage up to where they can make a profit. It is really, dude, our system is so jacked up, you guys. If you think this is even messing around, like, it is so jacked up. This is such a sometimes you just want to take a nuke, flatten it all, and rebuild it from scratch. And I will tell you, if this doesn't lead, for better or for worse, to a single payer plan that destroys all of this, nothing else will. There's nothing more aggressively damaging to us than this. The trends in annual EpiPen out-of-pocket spending per patient. Look at this graph. That's not okay. And look, some of it is copay, which is flat. Some of it is deductible, which has been going up because insurance companies have been charging higher and higher deductibles. And then co-insurance. So, and the out-of-pocket pay is skyrocketing. That's that black line at the top. This is not sustainable. So experts say that health plans really don't know how much of the rebate is coming to them because the PBMs don't necessarily have to disclose it to them. Also, health plans don't necessarily get to audit what a pharmacy benefit manager is keeping in those rebates. So they may get $100 on a Lipitor prescription, let's just make these numbers up, and they give $10 back to Aetna and say, you got your rebate, we're doing our job, and they keep $90. And who would ever know unless they are directly audited by the insurance companies? This is the problem. This is what they mean when they say it's a black box, the pharmacy benefit managers. So now here's what's happening. Pharma is using this as a nice tool to try to indemnify themselves when something comes up like EpiPen or insulin. They go, no, it's not us, it's the PBMs, right? I'm gonna go on record tonight and say it's all these a-holes. Like, all of them are responsible for this. And expectations from patients that they always get the best and the most brand name and non-generic drugs. And there's a whole, and doctors who are prescribing the newest stuff because, you know, the pharma rep brought them lunch. I'm telling you, it is a wicked, dense web that's very nuanced and very complex. So PBMs and their clients have even begun squabbling over their share of a piece that announced to $320 billion annually, or 10%, as Tom said, of the global healthcare bill. And Anthem actually sued Express Scripts, which is another one of the three big PBMs, because they were extracting an obscene profit windfall of $3 billion a year by failing to pass on all the savings it squeezed from drug companies in Anthem's name, right? And remember, drug companies are just then raising the prices to compensate.
So basically they were like, we want our cut. Right?
Yeah, that's what Anthem was saying.
Yeah.
It's like, no. I mean, you can't profit if we can't profit. Like, you know, it's like, it's literally like you took all the James Bond villains and put them in a room and were like, okay, Mr. Bond, all of these three villains are going to fight it out for who gets to kill you slowly and with plenty of advanced warning. That is exactly what's going on with this. So what's interesting now, here's an interesting solution to this problem. Boutique pharmacy benefit management companies are popping up everywhere. So they're saying, no, we're going to be transparent. We're going to tell you exactly where the refunds are going, and we're going to do it better than the big people. And some companies that have worked with them, particularly in Las Vegas, have found, ooh, this is saving us a ton of money. Potential solution number one. Potential solution number two, they are pissing, this is what happens. It's like when a shark, when you chum up the water with blood to try to attract sharks, okay? The first people you attract are the pharmacy benefit managers, the pharma companies, the insurers. Then who's going to come? Amazon and Walmart. So what's happening is Walmart and Amazon are like, I smell money, son. And they are now offering direct services. So it's very feasible for an entity like Amazon or Walmart to create a different kind of PBM, a competitive marketplace that will force manufacturers to reduce their prices. Wouldn't that be interesting? This may already be happening. Amazon is reportedly pondering an entry into the pharmacy business as insulin prices have soared. Walmart, and many Z-Packers sent me this link. Walmart began selling varieties of insulin, NPH and regular insulin, so these are old insulin types, which are short and intermediate acting, and again, there are many people who are on Lantus and more expensive insulins, for as little as $25 a vial. So this is already happening. And honestly, I think it's great.
This seems likely to happen because this happened in the grocery industry in the late 90s where the middlemen got squeezed out and all the big grocery chains, there's like 4 of them now, just buy direct. And that seems like something that could possibly happen in healthcare here.
Yeah, it's entirely possible. Which brings us to the second article really quickly, the Bloomberg article, Drug Costs Too High, Fire the Middleman. Again, to remind you, if you're just joining us, and there's Trump, which says tap for sound, and I would actually actively tap not to have sound there. Sorry, Logan. A decade ago.
That iPad is bigly, yo.
Oh, this iPad is hella bigly. This is the new 10.5-inch iPad with the pen. Look at that. Look at that.
Oh
I don't need the pen. I just want the pen. I just want the pen, and it's a tax write-off.
Get back to PBMs, yeah.
Back to PBMs. All right. Peanut butter and money. Are drug companies effing, or PBMs effing us all? So it's interesting. A decade ago, so Caterpillar, big self-funded employer, they said, you know what? These PBMs are costing us a ton of money. We're going to bring these services internally. So they have their own panel of pharmacists and doctors who determine what's the formulary they'll cover and how can they negotiate with insurers. And they are already saving tens of millions of dollars a year. So that's a big FU to the PBMs already. And even Trump got in the business. He was, slamming the market for astronomical drug prices, and he's a business guy, so he actually sees this affect the bottom line of his businesses. So that's probably why he's interested. So I think what we should talk about in Tribe Talk, Tom, is let's get into the weeds about this. How do we fix this issue with PBMs? Do they need to be more transparent? Oh, by the way, here's how they steal money. You guys want to hear this? This is amazing. This is amazing. Let's end with this. How PBMs can profit. Okay, first of all, they have spread pricing, just like in the stock market. So they charge clients more for some drugs than they pay the pharmacy for those drugs. So they actually operate on a spread. So they'll charge, the insurance one thing, and the pharmacy pays another thing, and they take the profit. That's effed up. Rebate retention. So they keep a portion of the drug maker's rebate, about 10% as compensation. We already talked about this. The thing is, we have no idea how much they're actually keeping, right? Because we can't audit those books. Keep in-house. So they steer patients to their own specialty or mail order pharmacies. So they're CVS is going to steer them to CVS, that sort of thing, right? For Caremark. And then the third one is my favorite, clawbacks. Listen to this. They take back the difference between a patient's copay. Let's say you have a $30 copay for a drug, and the actual price of the drug when the copay is higher. So there are some drugs where the copay of $30 is more than the cost to the PBM of the drug. They take the difference. So the patient still has to pay the $30 copay, but the drug only costs $10. And guess who takes the difference? The PBM. If that isn't a great way to get us really cheesed off for a Tribe Talk, Z-Pack, I don't know what is. Share this, hit like, support us on Patreon. We need your help to grow the show because we just got a studio and it's going to be dope. We're moving there tomorrow. Come right back. We're going to get uncensored and real with Tribe Talk. Peace.
We're going to talk about this picture where Z met John Scully. So come back for that, y'all.
Yeah,
also, Z, you're looking peak Vin Diesel today, I must say.
Vin unleaded. It's what I do.
Go, go, go.
I hate you so much, Tom Heineber.
I'm alright. Uh-huh.